I have with us, and I see him smiling over there, Dr. Filipe Santos from the Medical Council of Canada. Dr. Filipe Santos is an international medical graduate, special advisor at the MCC, and the Royal College of Physician and Surgeon, certified anesthesiologist, and assistant professor at the University of Toronto. Now, Dr. Santos joined the MCC in March of this year as an IMG Special Advisor and will be supporting the organization's strategic objective of actively assisting IMGs as they navigate the practicing landscape as physicians or future physicians, right? Let's take this keynote speaker's term. So future physicians to moving to other medical roles here in Canada, including through proprietary tools. Now, as RCPSC certified anesthesiologist and assistant professor at UFT, Dr. Santos received his medical education in Brazil, where he also completed medical school and his residency training, and later earned a PhD in pharmacology. All right. Informed by his own experience as an IMG, he has supported and mentored many others, hoping to practice medicine in Canada. He also has a very active social media presence, so high LinkedIn follower, LinkedIn count there, I was told. So for those persons who are listening, someone to connect with there, don't just send, that connect request without the note. I like to see sometimes the note to tell us why you're connecting. Please help me welcome Dr. Filipe Santos as he speaks to you today in this conference.
Hi, everyone. I really love to hear IMGs or internationally trained physicians speak because I relate in so many levels. And I think a lot of the people that are trained in Canada, that were born, raised, and trained in Canada, do not realize a lot of the barriers that we face coming in from another country. And it's hard. I don't blame them for not realizing because it's not their lived experience. But it is also, that is one of the reasons why I believe it has been so hard to start change, because you can't change what you don't understand, what you don't see, right? So one of the things that I think has helped is that, for example, I'm here representing the Medical Council of Canada as an internationally trained physician, and because I am an internationally trained physician, and that is a change in itself, because now we are in a position where we can share a perspective in a place where this maybe might not have been shared before. And there has been so many aha moments in the MCC where for me was something so clear, crystal clear things that I think needed to be, that I didn't even sometimes think that they were noticing. And that also changed my perspective as an international trained physician, where we don't have to, we don't need to feel like we have the burden to educate people about our barriers, but at the same time, it's really hard for us to get buy-in and to also get make changes if we don't help people understand what we feel, what we're facing, what are the challenges. So about a year ago, a year and a half, I started on Instagram and by myself trying to help clarify the pathways for internationally trained physicians, because I realized that not even Canadians understood the vast number of different options there were for licensure, and internationally trained physicians were lost in terms of which pathway to follow. And I was in a very comfortable and privileged position where I was already licensed, and I was able to follow a pathway that is quite uncommon in a way, because I got an academic license before I was able to take my exams and have a full license. And I completely understand and appreciate that that is the exception, that is not the rule. So I wanted to help people that were not able to get an academic license and go through other pathways. And as I started collating and having to learn about the pathways myself, I started putting all this information on a Word document, and when it reached like 50 or 60 pages, I was like, I think this needs to become an ebook and be shared with everybody. And when I joined the MCC, we quickly put that together as an ebook. We created a table like for clinical assistant, associate physician, and for the practice ready assessments to make it easy to compare the provinces. And by just disseminating information of what already existed, so many physicians already started getting licensed in itself. So I think that is the number one thing, is even just sharing what's already there. And then in parallel to that, we can advocate for changes. But it's even hard to advocate for change when you don't even fully understand the picture or how the landscape is. So I'm just going to start my presentation today about talking about licensing pathways. It is about an hour long, so brace yourself. I'm going to talk for a lot. And that is the reason for that is because licensing is complex. And one of the things that I have been pushing against is that when I do these talks, or when I, even at the MCC, when they go through my slide decks, they're trying to can we simplify it and put 3 or 4 pathways that applies to all provinces and I said, there's no way. It's so complex. We're trying to oversimplify. And when we oversimplify, we eliminate some of the possibilities that might be the only possibility for a certain ITP in a certain province. So I do need to talk about all the options because I don't know who's listening, and maybe that, I will mention an option that is for that person. And, while I'm talking, a lot of you will be saying okay, that's not for me, that's not for me. But eventually you might say, okay, that one would work for me. And that is why I'm going to go through all the possibilities, okay? I don't have any financial conflict of interest. If you follow me on Instagram, for those people that are online, I do speak my mind on Instagram. And when I'm on Instagram, I'm not representing the Medical Council of Canada or the University of Toronto. So that is my conflict of interest. But right now, and when I present at conferences, I'm always representing the institutions that I work for, which is the University of Toronto and the Medical Council of Canada. Okay, so I want to start by telling all internationally trained physicians that, as and resonate what our first keynote speaker said, you're not behind, and you do not need to feel that you don't have worth. You are just in a different system, and you just, it's not because you board a plane in your country where you're fully licensed and you get out of that plane in a country you're not licensed, that during that flight, your knowledge or your experience or who you are as a person changed. And I think a lot of people forget that after they're here for a couple of years. They start feeling like they're not competent, that they're not trained, that they're not a physician even anymore. Some people say, I want to become a doctor in Canada. Well, you can't unbe a doctor. You're already a doctor when you boarded that plane. And I'm speaking mostly to physicians, but this applies to all professions. And the matter is, how do you show your competence so that the assessors and the population here feel safe with the care you're going to provide? And also, you need to take in consideration that when you go to another country, it's not only about the medical knowledge, it's about language, it's about culture, it's about the local regulations and policies in place. So I can't, even though I was trained in Brazil and I'm licensed in Brazil and in Canada, I can't simply board a plane, get out of the plane in Japan, and decide that I'm competent to practice, because I'm not. I can't speak their language, I don't understand their culture, I don't know their policies. And that does not mean that, if everything was known to me in an operating room there. So if I was to go into an operating room where everybody spoke English and I had, only Western trained physicians speaking and talking and acting the way I do in Canada, I would for sure be able to deliver an anesthetic there. But if you drop me in the middle of an operating room where, the physicians, the nurses, everybody has their culture, their policies, their charting, I would not provide a safe care. So that is why we, as internationally trained physicians, we do have our responsibility of learning that piece so that we can apply the competence and the knowledge we have to provide patient care here. And I think that is the integration that we we need to fight for is how do we provide tools for internationally trained physicians to do that transition, to learn what they need, to apply their training and their knowledge to provide safe care here. Okay. So why does this matter to me? So I arrived in Canada in 2017, and I know that looks like it's way more than 8 years ago, but it's only 8 years ago. And all I wanted was to be a licensed physician in Canada. Like, that was my goal since forever. I'm not going to be able to talk about all my story here, but my parents immigrated to Canada when I was 7. And you went back to Brazil when I was 10 or 11, but I went back to Brazil as a Canadian citizen. And my dream was always to come back. But I stayed and did all my training in Brazil. So I've started researching, licensing pathways 4 or 5 years even before I arrived in Canada. And I started applying, sending emails to the Royal College, Medical Council of Canada, way ahead of time coming here. And so when I came, I had plan A to Z, but it did not include going back to Brazil. It included staying in Canada no matter what. And I started doing a fellowship, which is a subspecialty training within your own specialty in simulation and anesthesia education. Shifted completely my career from research to education. And when I went to, I told someone at St. Michael's Hospital, I want to stay in Canada, and the only option for me is to get an academic license. And at that time, I had done medical school, 4 years of residency, PhD, I was doing my fellowship, and they said, you don't have nothing to become an assistant professor. And I was like, kind of like, reality check for me. And it's like, you want to go into education, your PhD is research. If you want to do, become assistant professor and work in education, you need to have a master's or a PhD or have more, training in education. So I was, very sad and cried for a week. And then I said, well, I can stay crying forever and not get the job, or I can just go and sign up for a master's. So I got up, signed up for a master's, and did my master's at U of T in healthcare education. And then I came back after a year and I said, okay, now I want my job. And they gave it. So it was good. It was a learning experience for me. And it helped. I did understand that I needed to learn more about the education system in Canada to be in that role. But it is hard when you are doing so much education, or sometimes you feel like you've walked such a long path, and you look to your side and you see someone who's had the privilege of doing all that here, and you feel like you have to overperform to be able to be at the same level or be recognized for what you already do. So this matters to me because I walked that path, and I want other people to be able to do the same. And I don't mean, do academic career or do a PhD and a master's and a fellowship. I just mean understanding that sometimes you just need to find out where you're going, know what is your goal, your target destination, understand what are the possible pathways, and then once you pick your road, just make sure that you complete every single step. And at the end, they will have to license you. And that's what you need to, I think the shift is not, we're not, as someone said, they're not doing as, it's not about pity or, that they owe us a favor, but we are competent. We will be able to show that we're competent. We need to understand the rules of the game, and then everybody here is very resilient and will do what's needed as long as it's possible and there is a pathway. And I can tell you that because the system is so complex, there are so many pathways that it's very rare to not have a pathway for a physician. I've been talking with people one-to-one. There's usually always a pathway. If it's not for full licensure, which is usually possible, there is at least a pathway usually for role in medicine, such as a clinical assistant or associate physician, where you'll be able to have professional realization, have a good income, and be in medicine and not be working in non-clinical jobs if that is not what you want. And I say that because a lot of physicians want to work in non-clinical roles, and that's completely valid. But I hear a lot of people that want the clinical roles and can't achieve them. So I'm more focused in helping people achieve clinical roles. And I know there's other people that have way more experience than me in helping physicians that are willing to go into non-clinical roles. So I'm going to focus on the clinical roles. So at the end of the session, you'll be able to understand Canada's licensure pathways and how they differ by province. I want to also explain a little bit about the role of the institutions, because that's really important for people to understand. I found it very interesting what our first keynote speaker mentioned, that, you know, there's this, like, you work through exams to become a licentiate of the Medical Council of Canada, and you think it's a license because it's called licentiate. And then a lot of physicians realize that it's not a license, and the license is a provisional, so is by the provinces. So that understanding even of organization before you start the process is really helpful. And by understanding the pathways, you might find out that you don't even need an exam. So I find a lot of physicians are taking exams, they don't even know what they're going to do with it after, because people just told them that's the way, just take the exam. So they're spending time, resources, you know, not working, not being with their family, not traveling, doing all these things and sacrificing things they don't need to sacrifice when there's already a lot of sacrifice happening. So let's try to remove the ones that are unnecessary. So trying to help you identify the programs that might match your qualifications, the ones you already have, how to navigate provincial requirements using trusted resources, and strategically plan your next steps, no matter if you're a general practitioner, a specialist, or a subspecialist. Okay, so there's the overview. I'm going to talk a little bit about the Medical Council of Canada and our role in all this. I'll talk a little bit about nomenclature and why that's so important, why that's such a common issue for internationally trained physicians. I'll talk a little bit about where to start, and then the pathways for each of the groups. So general practitioners in family medicine, specialists, and then subspecialists. Okay. And I see a lot of people joining. We're 122 participants. So if you guys have questions on the chat, I'm not able to read the chat, but maybe if there's someone who's reading the chat and can let me know at the end, I'll save some time for questions and answers. So you guys can send the questions and answers on the chat, okay? So as I mentioned earlier, the MCC included assisting internationally trained physicians and international medical graduates as part of their strategic plan in 2024. And that was extremely important because it led to a lot of action happening after that, including creating a role for and a space for an internationally trained physician to join the Medical Council of Canada, which happened to be me. And it was a surprise to me. I never envisioned or imagined, especially when I was going through the pathways and taking the MCC QE Part 1 myself, that I would ever be in this role. I was invited, and it was a shock, and it was an honor. But the good thing is that I realized that I could bring that vision and help other internationally trained physicians. So the institution is taking steps towards that. And I think it aligns with the political landscape and the changes that are happening in the Canadian healthcare system, that we are in dire need of physicians. And Canada has now realized that we have this hidden gem that has always been there, these physicians that have always been around, but that can come into action way faster than opening 50 medical schools and increasing all the residency programs and waiting for, you know, people that are now in grade 12 to become cardiologists or cardiac surgeons in 20 years from now. We have cardiac surgeons driving Ubers that might be able to be, you know, operating on your family member, that we just need to help them, as I said, apply their knowledge and competence to Canada and the Canadian population. And that is much faster to do than to train someone from ground zero. So there is, as I said, when we get out of the plane, we're not competent to practice immediately, but that transition is much faster. And there are resources we can do and help that we can provide to assist those physicians in quickly becoming very competent to practice here. Okay. So how is MCC, the Medical Council of Canada, now supporting internationally trained physicians? So aside from my role, we have started to centralize a lot of information on the Medical Council of Canada. Historically, the institutions didn't really want to have a lot of skin in the game because there's always liability, right? Everything you put on a website, people are like, what if it's wrong? They're going to come back at us and say that we provide wrong information. And everybody's afraid of putting information on the website because it might be incomplete or it might be wrong. So, you know, if you go to the Royal College or the MCC website a while back and you looked for immigration information, they would just refer you to the link of the immigration website. And then if you went to find out about, you know, CARMS, link to CARMS website. And you want to find about like link, and it's always to the very homepage of the other institution, which doesn't help a lot. If you're at the MCC website and you're looking for pathways for immigration, you're looking for pathways for immigration for physicians, and then you go to the immigration website, they're going to be talking as well for pathways for immigration for, you know, forestry workers. That has nothing to do with what you do. And for you to dig that information on top of digging information for every single licensing pathway, on top of digging information for everything, like putting all that together is overwhelming. It's time consuming, and everybody's repeating the same process. Like everybody's doing the same exact thing and struggling to it and spending so much time and resource on it. So we kind of we're trying to centralize information that are relevant to physicians on a single website. So we started by the ebook that I mentioned before, which centralizes all the information about clinical assistant, associate physicians, and practice-ready assessment pathways. That is not all the pathways that are possible. So we started focusing on general practitioners in family medicine. So for specialists and subspecialists, the ebook is not as useful. Still, some of them may qualify for clinical assistant or associate physician roles. And at the end of the ebook, we do talk about practice-ready assessment for specialists, but that is the exception for a specialist. So the ebook right now is mainly for general practitioners in family medicine, but that is the vast majority of our audience. And you can use the ebook to, you know, understand the pathways, see which provinces match best with your qualifications. And then there are some links that are very specific for you to follow up on specific pathways. Aside from that, we're trying at the Medical Council of Canada to expand our preparatory products. So in the summer, for example, we will be providing 55 multiple choice questions that are examples and practice for international trained physicians free of charge on the website, so that people can understand how the exam is and understand how they're going to be assessed better before they challenge the exam. Okay. So one of the things that is important is to understand the structure of how licensing happens in Canada. And this is very important, and the vast majority of the physicians and the population do not understand how this happens in Canada. So I would like to very quickly explain this. So the Medical Council of Canada, the Royal College, and the College of Family Physicians of Canada, they're national organizations. So they're not provincial, they're national. And they're assessment and certifying bodies in the sense of they do not issue license. Okay, so even though the Medical Council of Canada can grant you a licensure of the Medical Council of Canada, that is not a license. They do not have the authority to let you work as a physician in Canada. It's not their role. That is not what they're built for, they're licensed to do, or they're authorized to do. Their role is to assess your knowledge in either medicine as a whole, or a specific part of medicine, such as specialty, a subspecialty, or, you know, family medicine practice, and issue you a certificate. Say, yes, I assess this person, they pass our standard. That is basically what these institutions do, okay? They do not issue license. Then we have the provincial bodies, the College of Surgeons and Physicians of each province. And those are the bodies that can give you a license. So they're called medical regulatory authorities. They, in Canada, they're autonomous in the sense of in a province, they are the ones who decide who can have a license or not. They do not need to match what other provinces necessarily do, although they tend at a high level when when you have a full license in one province, the other provinces will recognize that. But up to that point, they can have completely different requirements or eligibility or procedures for giving license. They can make their own licenses. So for me, it was interesting. In Brazil, there's 2 types of licenses all across the country. And here, only in Ontario, we have 13 different licenses. So I was like, what? Like there's 13 different licenses, each with different eligibility criteria, with different scope in the sense of like the physician that has one license and the physician has a different license, they might be authorized to do different things. One might be able to only work in an academic center, the other in the community. So there's so many different possibilities within a single province. Imagine that times 13, that it's just overwhelming. So it's important to understand that the national bodies are the one that I mentioned before. They assess you, they give a certificate, and then the regulatory authorities in the provinces, they decide what they're going to ask from you from these national bodies. So they might say, you know, you need to have the licensure of Medical Council of Canada, you need to be certified by the Royal College of Canada, and then you can work. But they might also say, you do not need that, and you can still work. So they are the authorities. They can give you a license regardless of what the national institutions are saying regarding your assessment and the certification. And that distinction is important because I get a lot of people coming and say, when is the MCC going to change the licensing requirements? And my answer is never, because we don't do them. It's the provincial medical regulatory authorities that will change licensing procedures. And we at the MCC can talk about examination, assessments, like the practice ready assessments. We have a big involvement, but we are certifying and assessment bodies. We are not licensing bodies, okay? So nomenclature matters because we throw a lot of words around in these websites and the medical regulatory authorities, MCC, that sometimes have completely different meaning for people coming from abroad. So, and sometimes it's counterintuitive. So for example, I'll give an example. What is considered postgraduate training? So in Brazil, we do 6 years of medical school with 2 years of internship at the end of our training. And that internship, is considered and valued as a postgraduate training, at least 1 year of those 2 here in Canada. But I hadn't graduated yet. So it's counterintuitive. It's postgraduate training, and now they call it pre-diploma internship, but it's still considered postgraduate training. But to me, it's a pre-graduate training because I hadn't graduated, but we still call it postgraduate training. So it's counterintuitive because I talk to a lot of ITPs, they're like, I don't have any postgraduate training. And I'm like, well, where did you train? And then they'll say, oh, they'll tell me the country. And how long was your medical school? 6 or 7 years. I'm like, well, you do have postgraduate training. Because, you know, if you had gone to a school, for example, the Caribbean, where the schools are 4 years and there is no internship, you would have to have that postgraduate training. After you got your MD, you would have to do that 1 year internship either in the US or in another country. And in your country, you already have to do it before you're even considered to be a doctor. So the nomenclature matters. It's important to understand that you might have training or, you know, credentials that you don't even know you have, and you're maybe not even applying for practice ready assessments because you think you don't have postgraduate training, and another requirement says you need to have 1 year of postgraduate training in family medicine. And then you did medical school abroad. You have 1 year of internship in general medicine, which aligns with what they're asking, but because you don't understand what they're saying and they don't understand what you have in terms of training, there's a gap. And that person that is competent to practice or to go through the assessment that already exists in Canada is not applying for that position. So that's why clarifying nomenclature is so important, that that people that already have the credentials or the training and they're eligible for certain programs we already have, we put them together. I'll give another example. So what's considered independent practice? So independent practice is something people don't understand, and it's so needed because every time you go to apply for a license, they'll say you need to have, or you go to apply for a practice ready assessment, they'll say you need 2 or 3 years of independent practice experience. And then people are like, well, what is independent practice? In my country, I'm called a medical officer. I hear it all the time, or a house officer. What does that mean? So understanding what that means is important. And in the Canadian, you know, terminology, when we're talking about licensing, independent practice means that you were the most responsible physician. So that means that if you complete your medical school and you have a license to practice in your country, and you went to a rural area where you were the only physician taking care of patients, diagnosing, managing, making decisions without supervision, that is considered independent practice. Even if you didn't have a specialty certificate, if you didn't do any residency training after your medical school, that is independent practice. Okay, now if you were in a supervised role, so you're doing residency training or internship, by definition, you are not independent because you're in training, okay? And some terms are very commonly mistaken for each other because they are the exact same word, but they mean completely different things. So, for example, it was a learning experience for me when I started working with a lot of physicians coming from countries that I had never worked with before. And I started, for example, now there's many colleagues from India where I work at St. Michael's Hospital. A lot of internationally trained physicians come to do subspecialty training with us. And they would say, I have an MD anesthesia. And to me, that meant, I didn't understand, like, what do you mean MD anesthesia? MD is medical doctor, which means you have a medical school. They're like, no, my medical school is MBBS. So I was like, hold on. And then I had to learn. So in some countries, the medical school will be MBBS, which is a Bachelor of Medicine and Surgery. And then the residency training, they call MD, and then the specialty. So what we call MD here, medical doctor, which is medical school, they call residency. So I asked them when they went to my Instagram, the first question was, are you an MD? And they would say no. I'm like, why are you here? And they're like, I had did MBBS and I did my internship and I worked as a physician. I'm like, well, then you are an MD. They're like, no, I didn't do MD. So then, that back and forth until I learned and I started using the correct language. So now I asked, did you do a medical school? And then people understand. And I say, did you do specialty training? So we need to change how we ask the questions, because if you go on the website and you ask, are you an MD? And they say no, that doesn't mean necessarily they're not a doctor. But we, like a lot of the people in charge of these institutions, don't even have that understanding, because it's not like, it's hard for us because we're not aware of how things are in every single country. Another example is internship. So internship for me was at the end of medical school, or as soon as you finish a medical school program, the first year of hands-on clinical experience, supervised training, where you rotate in different areas of medicine to gain clinical experience in all of the areas that are relevant. So usually most of the internships will have rotations in the big discipline. And then I went to talk to someone from Ukraine, and I said, do you have residency? I didn't ask if they had residency. I said, are you a specialist? They said yes. And then I said, okay, how many years of training? They said, I have 2 years of internship. And I said, well, internship is not specialty training. They're like, yes, it is. They're like, no, it's not. And we went back and forth, and I found out that residency training in Ukraine, they call internships. So and then the internship that they do during the medical school, they don't call internship because the internship is after. So I had to explain to them, I said, okay, from our perspective, the way we talk about things, you did an internship during your medical school because it was a 6-year program, and after medical school, you did a residency training. You're like, oh my God, like at home, we say that I did a medical school and internship after. So it's the same training, the same, what they did is what many other countries do, but because they weren't able to put on paper and explain in the same words we understand, they were missing out on so many opportunities, because if it didn't say internship, they wouldn't apply for it. And when they submitted their documents to the Medical Council of Canada, they would upload it as internship, because there's an option there, internship, but it wouldn't be accepted because they needed to upload it as postgraduate training that is not internship, like residency training, and they weren't doing that. So there's a lot of us that we need to learn, and it's so hard because there are 190 countries doing different things in the world. So it is also a challenge for us. But if we educate not only the physicians coming from abroad, but also the people here, we can start breaking a little bit of the gaps just by changing or explaining the nomenclatures. Even within Canada, and for people that are already here, it's very confusing. So clinical assistant, physician assistant, medical assistant, associate physician, clinical associate are completely different things. And they sound very similar. So I get that all the time where people say, how can I become a licensed physician assistant? And I said, well, unless you go to physician assistant school for 2 years, you're not going to become a physician assistant. Well, but I have a friend that is a physician assistant. I said, no, he's a clinical assistant. Oh, but is that the same thing as my friend is an associate physician in another province? And it's like, yeah, similar. Oh, okay, so I can apply for a clinical associate job. I said, no, because that's independent practice. So like they don't understand, and it's hard because I even had to learn all these. So here's a table where we'll quickly go over that. So clinical assistant or associate physician is an internationally trained physician. And the reason why it's always internationally trained physician is because if you did your medical school and residency in Canada, you're eligible for full licensure. So you wouldn't be applying for these roles. These roles were created for international trained physicians, where your training either doesn't match what's needed for a full licensure, or you're not there yet. You need to do that transition to practice in Canada, but you are able to provide patient care under supervision. So you work under a physician with a full license, under supervision, which can be closer or more distant supervision, but you're not an independent practitioner. So you're not an independent practice, which I just explained a little while back what it is. Not all provinces have these licenses, which makes it complicated. So in Ontario, we don't have them. So everybody working as a clinical assistant is not licensed. So it's an unregulated profession in Ontario, but it's regulated in most of the other provinces. The role of clinical assistant, it was always clinical assistant, and then there has been a more recent transition to calling the positions in this role as associate physician. So they are very similar, and they usually are mean the same thing. So clinical assistant and associate physician are very similar in what they do exactly. I'll just put like just consider they're the same thing. So they're synonymous. Physician assistant is a completely different profession. It's kind of like being a respiratory therapist, paramedic, nurse. It's a different profession. It's a health profession, but you need to go to a physician assistant school to be able to become a physician assistant. Yes, the daily work is very similar to a clinical assistant associate physician, but they're different professions doing a similar thing. So at internationally trained physician, if you want to become a physician assistant and do the certification or take the physician assistant board exam, you need to go through a physician assistant school. But if you want to become a clinical assistant or associate physician, you may be able to do it by just having your credentials recognized. So it's a different, two different things. Medical assistant is usually not a clinical role. You don't never need a license for it. It's usually the person that is in an office, a doctor's office, that will do the appointment. Sometimes they'll check heart rate, they'll check blood pressure. They will help to manage tests and orders and stuff like that, but they're not in a clinical role. You don't need to be a doctor. There is some other training that you can do. So you don't even need to be a physician to be able to be in this role. And now clinical associate is a term that varies a lot, but I've seen a lot of job descriptions that says clinical associate. And usually it refers to licensed physicians. So usually independent practice in a temporary or restricted role. And it's mostly used by hospital credentialing. So it's a term that we try to stay away from, but it's very commonly mistaken by as a clinical assistant or associate physician because it joins two words that are very similar. I'm going to talk a little bit about where to start. It's important to understand that licensing in Canada requires 4 big columns. And everybody has to have those 4 big columns. So I came up with a way of explaining this that I call the IMG-L framework. And IMG is easy to remember, and then we add the L for language. So I is for immigration. So you need to understand that you need to have some kind of immigration status. Either if you're a refugee, if you're a permanent resident, or if you're in a work permit, you need to be able to legally work and live in Canada. The second is the medical licensing part, which is what I'm talking mostly about today. The G is for gap. You need to understand that currency of practice is important, and you need to try to avoid as much as possible creating a big gap or being away from clinical work for too long, because it might be hard to afterwards break the gap and go back to being eligible for many positions. And language. You need to be proficient in English or French, depending on where you were applying for a job. If you don't have all 4 at the same time, it is going to be very difficult to get licensed. So you need to work on those at the same time. And I'm only talking about one pillar. And a lot of people kind of put aside, immigration, currency of practice, and language to work exclusively on the licensing part. And as other keynote speakers mentioned, when they finally reach all the requirements for licensing, because of the other three factors, because they don't have a PR, or because they didn't take a proficiency test, or because now they're out of practice for too long, the puzzle doesn't come together because you're missing other pieces, okay? So for language requirements, you can check the ebook. They're pretty standard for all the provinces. Physiciansapply.ca is managed by Medical Council of Canada, and that's where most of your credentials will be stored and verified. So that's a very important place to start. And about immigration, it's also very important to understand what are your options. We have now a part on our website that is called Where to Start for physicians. And there we list a lot of detailed information about options for immigration for physicians. We also list the language requirements, and we explain what current field practice means. So we're trying to address those before we talk about medical licensing, which you will find mostly on the ebook, okay? I always put this disclaimer because it's changing so fast. I think in the last couple of years, we saw more changes in licensing for international trained physicians than we've seen in the last 2 decades. Things can change without notice. So every time, if you see something on the MCC website or something on the ebook that is different than the medical regulatory authority has on their website or on their news, you need to believe the person who gives you the license, not the person who's trying to help you get to them. So the ultimate word is always the medical regulatory authority. So they're autonomous, they are the authority when it comes to giving license. So if the College of, Physicians of BC says A and I say B, you believe them. What they're saying is correct. And we're trying to catch up and share that information, but we're now not afraid of making mistakes, and we're still trying to share even if they might be inaccurate. But we will direct you to their website, and ultimately when you apply, they're the ones making the decisions. And if they say something different than your friend or what the MCC says or what the Royal College says, ultimately you need to believe and accept. And the rule is what the medical regulatory authorities are telling you. Okay, just to make that clear. So current field practice is important, and I will talk a little bit about what breaks a gap, but basically it's usually either going back home to practice independently, but slowly there are some options within Canada for specialists, like doing a fellowship, for example. But for people that are general practitioners or applying for family medicine licensing, there are some ways now to break a gap by being a clinical assistant or associate physician in Canada, and then applying for certain provinces for a practice ready assessment program. And I'll talk about that. So I'm going to go now into the pathways, and I know this was the main part of my presentation, but it's really hard for me to talk about pathways without having all this explanation first, because then I start talking about, internship or residency. People that might be from other countries don't really understand what I'm talking about. So for clinical assistant, associate physician roles, and for practice ready assessment in general, family medicine or for general practitioners, I would like to refer everybody to the ebook. So the ebook is available on the MCC website. It's free of charge. It's a PDF. We have been trying to update the ebook as changes happen. And because it's not yet a website, you do need to download it every now and then and check if the version you have is the most updated version. Because if we do a change, it's of course not going to update your PDF unless you download the updated version. And we're working towards making it a live website where you don't need to, be downloading the PDF multiple times, but that takes time. And I wanted to really put this PDF out as quickly as possible to share this information. So while we're working on the website for now, you might need to download the PDF multiple times to have the most updated version. But I'm giving some highlights here of some common situations and to give you some pointers on where to go into the ebook, okay? So if you are a physician who did not take the QE1 yet, and you're not a licensure of the Medical Council of Canada, there are some options. In Manitoba, you can apply to become a clinical assistant if you have the NAC examination, which is the OSCE from the Medical Council of Canada, or if you do their clinical assistant assessment program that only exists in Manitoba, and it's done by the University of Manitoba. So those are two options for you to get licensed without the QE1 as a clinical assistant in Manitoba. If you have more than 5 years of independent practice back home, so you practiced as a general practitioner or as a specialist back home for more than 5 years without supervision, so you cannot count internship or residency training. If you practice for more than 5 years, you can apply to become a clinical assistant in Nova Scotia, New Brunswick, and PEI without having the QE1. Okay? And because I am in Nova Scotia right now, Nova Scotia is the only one that accepts you to count training years as well to make up for those 5 years. So in New Brunswick and in Prince Edward Island, you need to have 5 years of independent practice. So it does not count training years. In here in Nova Scotia, it counts everything after you obtained your medical degree, or and also the year of internship. If you did a program that is like 6 years, it will count 1 year of that training plus your experience. So let's say you did a medical school that's 6 years long, and then you did 2 years of residency, and then you worked for 2 years. So you have 1 year of internship, you have 2 years of residency, and you have 2 years of experience. That makes up to 5. The College of Physicians and Surgeons of Nova Scotia, at the discretion of the registration committee, but if they accept those years, because it counts up to 5, they can accept, they may be able to give you a clinical assistant license without the QE1 exam or any other exam. In New Brunswick or PEI, you would have to show that you have 5 years of experience after, for example, your residency training. You complete your residency or your internship, or you were working without supervision and not in a training role either. Okay. For physicians that now have a gap, sorry, can we go back to that previous slide? Yeah, for physicians with a gap of more than 4.5 to 5 years, so you've been out of clinical practice for more than 5 years, you can still apply for a clinical assistant license in Manitoba. Okay, Manitoba is one of the provinces where physicians that have more than 5 years of gap can still get a license to be a clinical assistant, and that is important because that might be one of the ways to break a gap. Okay. Now, if you have a gap of less than 5 years, thank you so much. That's a sign that I'm probably talking so much. If you have a gap less than 5 years, you might have options in other provinces as well. So the reason why I put a gap more than 4.5 to 5 years, because when you reach that point, it's only Manitoba really that allows you to get licensed without breaking a gap. But before 5 years, you have other options. So between 3 and 5, there are some options for, especially for a clinical assistant and associate physician in many provinces. And I always encourage the physicians to really, the 3-year mark is a very big alert that you're going to start losing your opportunities in the next 2 years. So try to see what are the things that, how you can secure a license without delaying any further. And there are many, because then there's more options of places to live. Maybe you're already in a province where that is possible, but after 5 years, it's going to become harder. And then currently it's only Manitoba. For physicians that have no previous postgraduate training, no internship, no residency. So for example, you did a medical school in the Caribbean and you didn't do internship, didn't do residency, didn't do anything after, you can become a clinical assistant in Manitoba or Saskatchewan. Those are the 2 provinces that if you pass exams, you'll need exams. But if you pass the QE1 and or NAC, it depends on what province you're going, you may be able to be licensed in a supervised role, such as a clinical assistant or associate physician, okay? And for physicians that have never worked independently, but you might have done internship or residency, for example. So you might have done, you completed a 6-year program abroad where you did internship during your medical school, and then you came to Canada right after. You don't have independent practice experience, but you have that 1 year of internship. You may be able to be a clinical assistant or associate physician in multiple provinces if you pass one or other exam. So I think this is also something that a lot of people don't know, that it's really important. For a practice ready assessment, so what is a practice ready assessment? So a practice ready assessment, as the name says, it's an assessment to see if you're immediately ready to start practicing independently. Okay, so that is the role of a practice ready assessment. It is an assessment, it is not a training. Okay, so when you join a practice ready assessment program, you are assessed for a period of 3 months. And every day that you're there, you're being assessed. You're not being trained. Of course, you're going to learn in the process. We all learn all the time, but it's not a residency program. It's not a training program. You're not registered as a resident. You're not registered as a fellow. You are licensed with a provisional, even like the regulatory authorities will give you a temporary license to be assessed because you're being assessed. And if you complete those 3 months and they say, yes, you pass, they basically said you're ready to practice. And after that, you get a provisional license where you will be practicing independently, but it's provisional because you still will have some kind of limitation, either because you need to do a return of service for 3 years in a rural area, or because you will be assessed every now and then by like chart reviews until you go to a full license. But it is an assessment that will lead to an independent practice. Okay, that is the practice ready assessment. A lot of people have a misunderstanding that when they get into these programs, they're going to be trained or taught how to transition to practice in Canada, and that is not the purpose of these programs. Yes, that kind of happens throughout the 3 months, but ideally, you will come into that assessment having some kind of previous knowledge of what you need to do or what you need to know to be competent to practice in Canada. So I always recommend for physicians to work as a clinical assistant or a social physician in a supervised role for at least 3 to 6 months, so you can learn from the person who's supervising you, be in a role where you're not the one making independent decisions, so that when you come to be assessed, you're ready. And you don't fail practice ready assessment, because that will delay even further your licensing process. So to increase your chances in a practice ready assessment, you should at least try to work as a clinical assistant or a social physician, licensed or not. Some people in Ontario can't get a license in Ontario, but if you're with a physician and you work in that role for 3 to 6 months, your chance of success at a practice ready assessment will be much higher. Okay. So here are some highlights of what you will find in the ebook. So there's some provinces where you do not need to do the QE1 to be able to enroll in the practice ready assessment. Nova Scotia has been leading in so many ways the change that Canada wants to see, and we're very I'm very proud when I see all these changes Nova Scotia has been doing, and I'm kind of honored to be doing this week here because I can say it. And when I go to other provinces, it's kind of like, oh, yeah, Nova Scotia, is doing this, and you guys are not. It feels kind of weird, but I can say this because I'm here. But it is true. A lot of the PACE program, which I think today there's going to be a talk later today. Another keynote speaker will talk about the program, how innovative it has been. But even for specialists, the way internationally trained physicians are being considered ready for practice has been different in Nova Scotia. And I think it's leading the change for other provinces. So in certain situations, you might not need the QE1. Currently, for a practice ready assessment in general practice and family medicine in Nova Scotia, you do not necessarily need the QE1. If you have it, it might be an asset on the selection process, but it's not a requirement anymore. Same for British Columbia and Manitoba. Now, in Manitoba, you do need to have NAC, which is the OSCE exam from Medical Council of Canada, as opposed to Nova Scotia and BC, where right now you won't need to have any exam, or you can apply even if you don't have any exams. Okay. The NAC is the OSCE examination. There are multiple provinces that do not require that examination anymore, but some still do. Here's a list of the ones that do not require NAC. So British Columbia, Alberta, Quebec, Nova Scotia, New Brunswick. They all differ in other requirements. So I'm trying to group them by certain requirements that they have in common. You'll need to go to the ebook to understand what is the requirements, all the other requirements for each province. But some people that have not done NAC at all may be able to apply. It's just multiple practice rate assessments. There are options for people that are on open work permit. Most of the roles that require PR or citizenship will accept refugee status as well. But if you are not a refugee, not on PR, and not a citizen, but you have an open work permit, there are still some practice right assessments that not only might allow you to participate, they might help you secure a permanent residence status. There are some practice right assessments that accept 1 year of postgraduate training. So historically, most of the practice right assessment would require 2 years because that's how long family medicine training is in Canada. But there are many practice right assessments that accept 1 year if you have enough years of experience. So basically what they're saying is, you know, the standard in Canada is 2 years for us to give the license. But if you have 1 year and you have 2 to 3 years of experience, we will, you know, we understand that that experience might have made up for an additional year of training, and we want to see if you're competent instead of looking just at your training. So they will do the assessment, the practice ready assessment, the 3-month assessment to see if you're competent. Because some people with 1 year and 3 years of experience might have reached the level of competency that is needed to provide safe patient care in Canada, and some people might have not. So you need to go through the assessment, but they allow you to go through the assessment. Whereas in the past, we were so fixated on you need 2 years of training that these people were left out. They were not able to show their competence. Some provinces still require 2 years of postgraduate training, and there are options for people who have never practiced, but they did 2 years of training. So similar to the way it is in Canada, where you do 2 years of training, some provinces mandate that no matter what, even if you did 2 years of training, you still need to have had independent practice experience. But there are some provinces that say no, if you did 2 years of training, we want to be you can be assessed whether or not you're competent, and we'll let you participate in our programs. Okay. So check the ebook for full details, and remember to download it frequently so you don't miss out on updates. So here is a pathway for independent practice. So I already talked about clinical assistant, and I talked about practice ready assessment. The only part missing there is CARMS. So it is an option to apply for residency training in Canada. That is managed through CARMS. And when I come to do my talks, I usually don't talk a lot about CARMS because there's a lot of information that has been historically the traditional route, as people would say. So people know way more about that than how to become licensed without having to redo your training or do your training for the first time here. So for that, I will refer you to the CARMS website. They have a lot of information, and I just want to highlight that it is very specific, not only to provinces, but to specific programs. So you need, and when I say program, I'll clarify that because again, nomenclature, I mean the specific discipline you're applying for in a specific university. So by that I mean, for example, if you're applying for family medicine at the University of Toronto, it will be different than applying for dermatology at the University of Toronto, which will be different than applying for dermatology at the University of British Columbia. So you need to look at the program, specifically the specialty and the university and the province. They have different requirements. So all of this is on CARM's website, and you can find that information. But it's pretty standard that you need to have both of the Medical Council of Canada's examinations, the QE Part 1 and NAT, to be eligible. And you usually need to be either in a refugee status or have permanent residency or be a citizen. There are exceptions. I have listed them there. So Quebec and Newfoundland might accept your LMCC to replace NAC. So basically, if you pass QE1 and you did at least 1 year of internship or residency, and you're able to get become a licensure of the Medical Council of Canada, they may allow that to replace NAC. Quebec, since last year, has been the first province that allow people without the permanent residency to apply if you have an open work permit. And Nova Scotia, again, is the only province that accepts the USMLE Step 1 and 2 to replace the MCC QE Part 1. But you still have to take NAC. So if you did the Steps 1 in the US, 1 and 2 in the US, and you have the NAC from Canada, you're able to apply for CARMS in Nova Scotia only. Okay? So now I'm going to talk about pathways for family medicine if you come from an approved jurisdiction. So approved jurisdiction is a term also that we throw around a lot. And I just want to explain that approved jurisdiction just means that, you know, a group of people selected some countries where they believe the training is very similar or the practice of medicine is very similar to what we already do in Canada. What the College of Family Physicians of Canada and what usually the medical regulatory authorities consider as approved jurisdiction for family medicine is not the same as what they consider approved jurisdiction for specialties. So that is confusing in itself, right? Because someone who's a family doctor, for example, in South Africa, will not be considered approved jurisdiction. But if they are an anesthesiologist in South Africa, they are considered approved jurisdiction. So the same country might be approved jurisdiction for specialty, but not for family medicine. And this, the opposite is also true. So for family medicine and general practice, the approved jurisdictions are Australia, Ireland, UK, and US. So if you are from one of those 4 countries and you did your training, you completed your training, you passed the board exam, you got a license there, then you have a lot of options to practice in Canada, because the College of Family Physicians of Canada will give you the certification. So they'll allow you to use the term CCFP, so that you're certified by the College of Family Physicians of Canada, without doing any examination. So that really speeds up your licensing process, because the medical regulatory authorities see that certification as an as a testing that you're competent to go to start your practice. So they'll give you a full license right away. If you did your training in the US, there are multiple provinces that will allow you to be licensed directly. If you did not do your training in the US, but you're certified and licensed in the US, so for example, you did your training in Brazil, you went to the US, you did all the steps, you did everything needed to work and be licensed there, and you're already working in the US, the only province that will assess your situation and may grant you full licensure is Nova Scotia. So you can apply, the registration committee will see where you're practicing, what's your experience, but they may, it's up to their discretion, but they may issue a full license, as opposed to all the other provinces require your training to have been done in one of these approved jurisdictions. Also innovative in Nova Scotia is that if you have a registration and a full license in Australia, UK, or New Zealand, no matter where you did your training, if you have your register and you do have a full license there, Nova Scotia will give you a defined license. A defined license is an independent practice license, where they will assess you for a period of between 6 months and 24 months, and then make a determination whether or not you can move to license without supervision and without expiry. Okay, so for example, if you're licensed in New Zealand, the only province that would allow you to come and already get a license without doing any exams or anything is Nova Scotia. So that's why when I try to, people try to simplify things, you might miss people. So, if someone's listening, they're like, oh, I'm licensed in New Zealand, I did my training in India, they could come to Nova Scotia without any exams and not have, the gap or be out of practice and then lose that opportunity. So now I'm going to quickly talk about specialists and subspecialists. This is the end of my presentation. I just want to say that for subspecialists, it's really hard. It's the most difficult group of physicians to get licensed in Canada as of now. So I will talk a little bit about that. So as I said, what is an approved jurisdiction differs between if you're a family doctor or if you're a specialist. But this that I'm going to talk now is for any country. I'll talk about approved jurisdictions on the next slide. So no matter what country you come from, you can ask the Royal College to assess your training. And when they do this assessment, they're only looking at your training. So someone who just completed a residency or someone who's been working for 20 years, they only look at your training. They're not going to look at anything other than your training, okay? So they're not looking at your experience. They're not looking at anything else. If they consider that your training is similar to the Canadian standard, they will give you what we call eligibility. The exam eligibility basically means you can write for Royal College exam. That's all it means, okay? However, after the Royal College, that national body that only assesses and certifies and does not give license, but if they tell you and give you a letter saying you can write your exams. Just with that eligibility, some of the provinces will use that information to allow you to get a license. So Nova Scotia, for example, was the first one to do that, where if you have the eligibility, even if you don't have any of the Royal College exams, you can have a defined license. In New Brunswick, PEI, and Newfoundland, it's called provisional license. And when you get that license, it's independent practice, but you're supervised, so you need a job offer. But after 6 to 24 months, you'll be able to move up to a long-term license that is not supervised. If you pass your exams, then other provinces also will use that information that you got eligible and you passed exams to allow you to work. And there is a common misconception that after you pass your exam, so if they allow you to sit the exam and you pass the exam, that you become a fellow of the Royal College, and that is not true. You need to have worked 2 years in Canada in addition to passing the exams to become a fellow. But you do not need to become a fellow to be able to start working. Okay, maybe just with eligibility or with eligibility in the exams, you might be able to already start practice and not create a gap. Okay, be current in practice. If you're not eligible for practice eligibility, so let's say your training does not meet the Canadian standards, the Royal College does not grant you eligibility, there are some other options which are usually the exception. But you can go to an academic license if you're if you're offered a job at a Canadian medical school or university. You might be able to get a special license in New Brunswick. If you have 2 years of fellowship, you might be able to do a pre-licensure assessment in Saskatchewan, which is basically a practice-ready assessment for specialists. Or you may be able to do a practice-ready assessment for specialists in Alberta, Manitoba, Quebec. Nova Scotia typically always had a practice-ready assessment for specialists. But because of all the changes with how they accept eligibility and all that, that program has kind of stopped. I don't know if it stopped completely, but it's mostly Alberta, Manitoba, Quebec that is doing that right now. Next slide. If you are a subspecialist, it's pretty much the same. What I'd like to highlight is that if you get eligibility by the Royal College, in your primary specialty, that's usually the best way to start in Canada, in your primary specialty instead of the subspecialty. And if you do a fellowship in Canada that lets you sit the Royal College exam in the subspecialty and you pass those exams, most of the provinces will allow you to practice in the subspecialty that you did your training in Canada, even if you're not licensed to practice in the primary specialty. So for example, you did neonatology, 2 years of neonatology fellowship in Canada. You set the Royal College exams for neonatology, and you passed. Most of the licenses will allow you to practice in neonatology, even if you're not allowed to practice in pediatrics, general or core pediatrics. So you would be able to practice as a subspecialist. Okay, that's called CEAP, and you guys can afterwards, I think they'll provide the recording, look at the slides and have a little bit more information. If you're not eligible for PER in your primary specialty or the CEAP in your subspecialty, the options are pretty much the same as I said, as for specialists that are not eligible for the PER. So you can still apply for academic license, special license in New Brunswick, or do a practice-ready assessment in Alberta, Manitoba, Quebec, and Saskatchewan have the pre-licensure assessment. I think that's nice. If you're from an approved jurisdiction, so the list of countries are here on the left. These are usually the countries that are considered approved jurisdictions. It will differ by specialty, so you do need to access the document of the Royal College because it differs by specialty, and some of them is only after a certain year that they accept. So you need to have completed your training after like a certain year. But if you're from one of those countries, the most recent change is that Alberta will give you a full license right away. I believe that other provinces, such as Nova Scotia and BC, are going to move in that direction very soon. But if you're not able to go straight for a full license, most of the provinces will allow you to get a provisional license, and after a certain period of time, you're able to move up to a full license. Okay? And if you're trained, certified, and licensed in the US, many provinces are giving you full license right away. This is a recent change as well. Okay, and this doesn't matter if you're a specialist or a subspecialist. It applies for both. Okay, that is the end. I'm sorry it was a very long presentation. I only left 7 minutes for questions and answers, but I would be happy to entertain any questions that I can answer in that period, that time. My Instagram is there. I respond a lot of questions through my question boxes on my Instagram, so feel free to send your questions to me there. And follow us also on the Medical Council of Canada Instagram, because we will post information about programs there as well. Thank you so much for listening for so long.
Okay. Awesome timing, Dr. Filipe Santos. All right, so we do have some questions here, and I'll start with one pertaining to recent of practice.
Yeah.
And especially within Pegasus as well, we do have quite a bit of internationally educated medical professionals who have fallen out of recent of practice and are of refugee status, cannot go back to their country practice. Are there any strategies to navigate this process?
Yes. So it depends on how long the gap has been, okay, how long they have been out of practice.
Okay, so give us some timelines, because yes, I can tell you we have from 10 years out of practice, we have some with 5 years, it varies.
Okay, so less than 3 years or 2.5 years, less than 2.5 years, you can still participate in most of the practice ready assessments, which will lead. So I'm only going to talk. Do you want me to talk about general practice and family medicine or specialists as well? Because it's different.
Okay, so the main pathways. So we look at PRA, and for those who know, most times the province they last for 24 months, 36 months.
Yeah, but you're talking. Right. So you're talking about general medicine. So and family. Okay. I'll talk about specialists.
The specialties. So tell us about general medicine.
Yes. Okay. So I'll talk about specialists later, but for you to participate in practice ready assessments for family medicine, they usually require that you have practiced within the last 2 to 3 years. That is the pathway to full licensure that exists. However, if you're between 3 and 5 years, you're able to apply for clinical assistant or associate physician in most of the provinces. And if you work as a licensed clinical assistant or associate physician in any province in Canada, excuse me, but it has to be licensed, so Ontario doesn't count, for example. There are 2 practice ready assessment programs, 2 provinces that are accepting that time as a licensed clinical assistant or associate physician to break the gap. And those provinces are Saskatchewan and Ontario. So, for example, you have 4 years of gap. You're not eligible for any practice ready assessment program at this time, but you are eligible to get a clinical assistant license in Nova Scotia, for example. You become licensed and you practice for 6 months in Nova Scotia as a licensed clinical assistant. You broke the gap for practice ready assessment Saskatchewan and practice ready assessment Ontario. So after working here for 6 months, you're now eligible for Ontario and Saskatchewan, and you weren't eligible before. So that's a way to break the gap. Now, if you have more than 5 years of gap, which means you're not able to get a clinical assistant or associate physician license in most of the provinces, the only option in Canada to break the gap is to become a clinical assistant licensed in Manitoba. So Manitoba does not look at gap, no matter if it's more than 5 years, 5, 10, 20. If you get a job as a clinical assistant and you get a clinical assistant license in Manitoba, that would break the gap and allow you to apply for the practice ready assessment in Saskatchewan or Ontario if you fulfill the other requirements. So you still need to have at least 1 year of internship with the rotations they require. You need to have 3 years of experience if you only did 1 year of internship. If you did 2 years of training, so 2 years of internship that they accept, or you did 1 year of internship and 1 year of residency, or you did 2 years of residency with the rotations they accept, then they might require less experience. Saskatchewan will not require any experience, and Ontario will require only 2 years. So for Ontario, 1 of training plus 3 of experience, or 2 plus 2, 2 of training, 2 of experience. In Saskatchewan, 1 year of training plus 3 of experience, or 2 years of training, no experience needed. So if you have a big gap, but you have previous experience or previous training, but you have a 10-year gap, and you go to Manitoba, become licensed there for 6 months as a clinical assistant, you're then eligible for Saskatchewan and Ontario to do the practice ready assessment. And if you pass, you have a full license. Or you have a provisional license that will lead to a full license.
Okay, awesome. So you mentioned for general practice there, that's good. And we do have some other questions pertaining to that. I see Vera Tao has her hand raised. Vera, I'm going to ask you to unmute your microphone and ask the question, please.
Yeah. Yes. Thank you for the chance for asking a question. Like my question for Dr. Santos is like you mentioned just now, like if we can practice as we can get a clinical assistant license to break the gap for the PRA, but for the PER, can we do that? Does it apply for the PER?
You're talking about specialists.
Yes.
Okay, so PER, that's why I said it was different. So now for specialists, if you have the PER eligibility, so to get the PER eligibility, they do not look at gap. Remember that I said they only look at training. They don't look at experience. They don't ask English proficiency test. They don't look at anything else aside from your specialty training. If you're eligible, if you've got eligibility,
yes,
for your so you got the PER eligibility, and now you got a job offer, but you've been out of medicine for more than 4 years and a half.
Yes.
Then the only way to break the gap as a specialist currently is going back home. So if you reach 4.5 and you're a specialist, you cannot get a defined license or a provisional license or do any of the routes for specialists if you don't go back home for at least 3 to 6 months. Now, you may be able to, so some of the specialists are able to go through the practice ready assessment in family medicine if they decide to be family doctors in Canada. But if you are a specialist and you're hoping to get, go through the specialist pathway, you have options up to 4.5 years out of practice. After that, you will need to go back home for 3 to 6 months at this time. There's no alternative that I know of in Canada.
Okay, so the gap is like 4.5 years, not 3 years.
Yeah, 3 years. You can still usually, most of the medical regulatory authorities will give you the license if you fulfill all the other requirements. So, for example, in Nova Scotia, if you find a job offer and you have the eligibility, you're eligible for a defined license. Yes. The registrar will usually issue a defined license if you're with if you have practiced within the last 5 years. So, if you have practiced for at least 6 months within the last 5 years. One of the options that you can use to break a gap is a fellowship program. So if you do a fellowship in Canada, that is considered training, it breaks the gap and you're allowed to then get a license. So let's say you have 5 years of gap, but you're able to get it, be accepted for a fellowship program, and you do that fellowship for 6 months at least, you can then, you become eligible again for licensure.
Okay. Okay, thank you so much.
No worries.
Awesome. So we do have quite a bit of questions here in the chat. We're not able to respond to all of these questions in the interest of time. So, Dr. Santos, I'm not sure if that is okay with you.
Yeah, of course. Yeah, thank you so much. I want to thank everybody that was online.
Continue, then that would be awesome. Thank you. So thank you so much for this very informative, power-packed discussion that you've had, and also responding to the questions from our participant. At this time,